and happy Hanukkah to everyone here. How great would it be if we start getting the vaccine in our arms before Hanukkah is over? I'm looking forward to that. I want to add that I'm so proud of what our Maimonides Society has contributed to healthcare in the Lehigh Valley. And I'm also proud of the financial help that our members have provided in maintaining Jewish institutions and community. This has been a pretty rough year. Please continue to think about our community needs and your capability in meeting these needs. We are all lucky to have pretty good jobs that were, at least us Maimonides members, which were relatively unaffected by COVID. Also, please think about saving me the aggravation of tracking all of you down in making your 2021 pledge. You know, we are unfortunately a little bit behind our pledging from Maimonides compared to last year. I think that's because we had a really nice happy hour where everyone, all they had to do was sign the card in the back. And I'm asking you, if you have not pledged, to just say yes on the chat box, and Aaron and I will consider that an affirmation. Anything you pledge between now and December 31st, 50% of any increase compared to last year will be matched by a donor, which will really help all of our institutions that badly need the help this year. And you have until December of 2021 to pay that pledge. So that's very, very important. I can't overemphasize that. As Aaron mentioned before, I did have some goals becoming Maimonides president, and there were actually three. One was planning a bike and hike trip to Israel for members or anyone else who wants to join. The second was bringing in younger members to our group. And the third was to talk about healthcare inequities. I think that today's talk will help on number 2 and number 3, but I don't see that as helping us with the bike trip at this point. So today's, let's see, another page, here we go. Today's topic is LGBTQ+ issues in medicine. I know this is a topic in which we have not been properly trained, and yet we need to be. There's 11 million adults who identify as sexual or gender minority. Many have significant healthcare needs that can be quite unique, and as a group have to have access issues as well. I want to introduce first the 2 lead speakers. The first one is my next door neighbor here, Rebecca Markson. She is a first year, this is the first time no, not a first year. This is the first time we're having a resident give a talk from Maimonides. So I think that's a Hall of Fame moment. Rebecca moved to Allentown in 1991 when she was born, yeah. And she moved around a little bit. First she lived in Deerfield, and then she moved to the Springhouse Farms area, where she tended to settle down. And apparently she likes this area because she came back to do her residency at St. Luke's in family practice. Since coming here, since coming back, she has been involved in St. Luke's initiatives to educate providers on today's topic. Also, I should add that she is one of my 3 favorite children. The other co-presenter is Dr. Nicole Deffenbaugh. Nicole is a clinical communication specialist and medical educator at St. Luke's University Health Network. And in that role, she provides graduate medical education in the area of professionalism, interpersonal communication skills, and diversity, equity, and inclusion to residents, fellows, and faculty. Before joining St. Luke, she was the Director of Education for the Department of Family Medicine and Director of Advanced Care Planning for the Department of Community Health at Lehigh Valley Health Network. She is also an associate professor at Temple, where she teaches narrative medicine. So I'm so happy to have both of you here. I've heard parts of this presentation before, and I'm so happy to bring this to our group. Without further ado.
Hello, everyone. I'm so happy to be here today with Dr. Deffenbaugh, and then later on, we're going to bring in Deb Strauss and Sandy Messick. So here's our topic today, as my dad nicely explained, so we can go to the next slide. Oh, yeah. So here are our objectives. We're going to explore factors that impact health and health disparities, learn some LGBTQ plus terminology, review some inclusive language and phrases. We'll recognize some community resources, and then we'll have a panel and Q&A. So if you come up with any questions during this lecture, we ask that you type it in the chat box, and we are going to address it later on during the panel and Q&A. Next slide. So I just wanted to take a moment and think about, have you ever do you personally know someone who identifies as LGBTQI? And for those of you who don't know what that stands for, that's lesbian, gay, bisexual, transgender, queer questioning, or intersex. Sometimes use the plus to denote that this community also is more encompassing than just those terms that I just listed. And have you ever encountered a patient who is LGBTQ+? So next slide. Back one slide. So if you think you haven't, it's more than likely you haven't, didn't realize. Case in point, right here. I'm a part of the community. So anyway, a recent study in Gallup in 2017 suggests that about 4.5% of the population identify as a sexual or gender minority, or as LGBTQ+. And these numbers continue to rise. So the Williams Institute of UCLA School of Law showed that there's at least 3.3% who live in Pennsylvania and 3.8% who live in New Jersey. So if we take into account the entire Lehigh Valley population, that's about 32,000. 32,000. And there's 11 million adults, as my dad pointed out earlier. Unfortunately, LGBTQ plus individuals experience tremendous social and health inequities compared to the general population. And to make matters worse, as my dad said earlier, accessing medical care can be extremely difficult or impossible due to tremendous barriers faced. And we will go into this in the next several slides. Next slide. So here's a nice fishbone diagram that demonstrates kind of different components that can contribute to these health disparities. Of note, this is by no means an exhaustive list. We wouldn't have space for that here, and can't really fully capture the levels and depths of these issues. But I just figured these three were pretty relevant to our topic today. So from kind of a group perspective, we have systems that comprise of the barriers to care. So as my dad mentioned, medical training is often inadequate. Unfortunately, a recent study in the Journal of the American Medical Association in 2011 demonstrated that on average, medical students only receive up to 5 hours of didactic learning and at maximum 2 hours of clinical experience treating this population, which is often inadequate to make providers feel competent in their care. Additionally, there are certain laws and policies that promote and further enable discrimination that can worsen health. For instance, until gay marriage was not recognized by the Supreme Court in all 50 states, depending on where you lived, same-sex partners could not have benefited from their partner's health insurance. And that was really only 5 years ago. At schools where there's non-inclusive discrimination policies, or like LGBTQ groups, youth tend to have higher rates of psychiatric comorbidities and suicide attempts, and that's reduced when you do institute those laws and policies. And additionally, not all insurance providers cover for LGBTQ specific care, which unfortunately things such as providing gender affirming hormone therapy has shown to benefit this population. So it's really further worsening health disparities. For the provider perspective, Nicole's going to go into bias. Oftentimes there's insufficient providers for LGBTQ specific care, and part of that could be because of lack of training and the lack of cultural competency, again, because of lack of formal training. We'll go into the patient perspective a bit later on, and Nicole's going to go into bias. Next slide.
So here's a definition of implicit stereotype or bias, also known as unconscious bias. And what we're talking about here is these attributions of a particular quality to a member or a group. And they are automatic associations. So we don't think about them, they just happen very quickly. And they're often learned at a younger age. So when we're children, we learn from our parents and family members and community members and our religious organizations and our teachers about how to think and feel toward particular individuals of particular groups. And so these implicit biases just happen without us really thinking about it. So for example, you might already have certain biases that you might think about us as speakers because we're talking about this topic, or because of who we are and the bios that you heard of the work that we do. And so the recognition is that bias doesn't always have to be negative, it can also be positive, but we all have these biases, and being aware of them is the first step. So what I'd like you to do, we want this to be as interactive as we can, recognizing we're on a virtual space. So we're gonna ask you to think about and perhaps even write just for a minute about what you've seen or experienced in healthcare regarding bias. So
Nicole, don't forget this is a Jewish group. People will just shout out stuff too.
That's fine. That's also fine.
That's bias.
Yep.
Case in point right there.
Yep, that's a great example. So if you would like to share, you can put your comment in the chat box. That's also another option as well. We're going to move on though. So Erin, if you could advance to the next slide. Thank you. And so bias really does have long-term detrimental effects. It can result in poor patient care. So if we're not aware of how we're thinking about a patient when we walk in, or we look at their medical record and we look at and see certain information about their sexual orientation, their gender identity, their relationship status, etc., that really does affect the care that we provide. Can also result in reduced health outcomes. So recognizing that Becca had said this really affects and impacts our entire community as well. And that leads to also increased health inequities. So it really is important to be aware and cognizant of your biases because they do influence the ways in which you care for patients. Next slide.
So I thought this slide really helps point out the patient barriers and experience. So according to the United States Transgender Survey in 2015, which surveyed nearly 28,000 transgender individuals in the US, this is the largest survey of its kind. 1 in 4 had issues with insurance for transgender related care or routine care. 1 in 3 had at least one negative experience relating to being transgender. And 1 in 4 did not seek the health care they needed due to fear of being mistreated as a transgender person. These same disparities are experienced among other identities within the community, with at least 18% or 1 in 6 LGBT individuals avoid seeking care due to fears of discrimination. And these discriminatory experiences are real, and we're hoping that we can kind of go through some of those personal experiences at the Q&A panel. Next slide. So unfortunately, all these disparities really leave the deck stacked against LGBTQ plus individuals, as many experience health issues at disproportionate rates compared to the general population. Before going into depth, it is important to note that all this can be influenced by the barriers I described earlier and sociocultural experiences and discrimination that many sexual and gender minorities have and continue to face. Oftentimes these disparities are intersectional as well, meaning that other identities such as one's religion or race can influence these disparities. So for mental health, United States Transgender Survey found that there's a 9 times increased suicide rate among transgender individuals. And the CDC reports that among youth, the rate of LGBTQ suicide is 5 times that of the general population. And among those, when families reject them, that rate goes up to 8.4 times that rate, which is, pretty monumental and scary to hear. So for substance use, there's twice the rate of smoking. According to the Community Health Needs Assessment in Pennsylvania, the rate is 30.2% compared to 18% of the general population. And there's increased rates of other substance use as well. There's also increased health disparities in terms of sexual health. So the CDC reports that 69% of new HIV diagnoses in 2018 were among men who have sex with men, with rates being highest among transgender women and transgender women of color in particular. So for cancer, there's suggested increased rates of cancer due to reduced rates of seeking primary care and appropriate cancer screening. And as Nicole mentioned earlier, sometimes what factors into that is bias that, lesbian or bisexual women might not even need cervical cancer screening. So there we see a specific example in where bias plays into these health disparities. It might also be due to increased risky behaviors such as sexual behavior and increased rates of substance use, which, as we know, smoking and other substance use increase rates of various types of cancers. They also are at increased rates of being victims of violence and abuse and high rates of homelessness. So the UCLA estimates that LGBTQ make up 40% of homeless youth, with often the reason being personal. So 26% of those who are homeless were kicked out of their homes for disclosing their sexual orientation or gender identity to their family. Next slide. So, we did go over a lot just then, and the point is not for you to memorize every little percentage or detail. It's really to drive home the fact that, this is an at-need population that is marginalized in society and in healthcare. And because of the barriers faced, they're at increased risk of certain diseases in compared to the general population. Disparities are often multifactorial and intersectional and varies within the community. Having things like a supportive family, a supportive community can mean a world of a difference for some people. So we are an essential element of the healthcare system. And if you're not in healthcare, of society that can at least try to address barriers to care and health disparities. And we'll go over ways that everyone can help out later when we talk about inclusive language. So by improving our knowledge, hopefully we can help break the cycle and do better for our community. Next slide. Also, just want to briefly mention that the chat was initially disabled, but is now active. So if you were having issues typing the chat box before, you shouldn't have any issues now.
So many Americans refrain from talking about sexual orientation and gender identity or expression because it feels taboo or because they're afraid of saying the wrong thing. So if I asked all of you, if we were in a room, I would say, show of hands, how many of you feel that you're afraid of saying the wrong thing? And so recognizing that there's so much language out there and so many different types of words, we're often afraid to even say anything to a patient. And as a result, we end up in some ways exacerbating the same taboos and stereotypes, to that population. Next slide. So here on this next slide are examples of different language. And so recognizing that we definitely have a wealth of language to really help represent the diversity within the LGBTQIA+ population, such as polyamorous, two-spirit, agender, transgender, intersex, lesbian, queer, etc. When we show this slide, it's not to tell you that, and Becca had said that you need to know all of these terms, right? So you don't have to know the definition of all of these terms and to know what they all mean. But the important part is to recognize two things. One is that there are many different terms, and the terms really represent the constant change in language to really represent the diversity of the individuals, all of our LGBTQIA community members. The second is that you don't have to know them, but you need to ask the person about the language that they use to represent themselves. So how do they express their identity? And that's what's really important. Next slide. So we're going to see where we're at. We're going to test your knowledge here, see how much you've learned so far. And we're going to ask you to participate in the chat box. So question number 1 is, I know someone's gender identity because of how they dress, behave, and present themselves. Do you all think that is true or false? Okay, we already have people participating in the chat box. Excellent. Got a number of false. Falses are.
You guys are a smart crowd.
I know, right? On a Sunday, really.
Can't fool you guys.
Excellent. I think the group got it. It's false. Excellent. Thanks. Erin, can you do the next one? So true or false, sexual behavior always dictates sexual orientation. So you find out about the sexual behavior of your patient and that dictates their orientation. Is that true or false? I'm getting a couple of false. I got a nope. Flat out nope. That's good. Some more false. Okay.
Yeah.
Yep, they're on a roll. We're doing well. Okay. And then the final question. How do you know someone's pronouns? Erin, can you press the next? So we're going to give them choice A, B, or C. A by their sex, B by their gender, or C if the person tells you. So how do you know someone's pronouns? A, B, or C? By their sex,
Woohoo!
Gender, or the, yeah, nice. We got lots, all C's, and someone said ask. Excellent. Okay, yep. They're killing it. Good job. Erin, can you go to the next slide, please?
Okay, and then click again. Okay, just, yeah. So yeah, you can keep clicking through until we get to gender. Perfect, so you can leave it there. So I'm gonna kind of go over these terms, you know, assuming that we do have a mix of experience and knowledge base here. So I'm sorry if this is repetitive for anyone who knows a lot about this topic. So first, I wanted to go through the difference between sex and gender. So sex is often what's assigned at birth. It's often defined biologically by genetics, chromosomes, or genitalia at birth. It's kind of out of favor to say that sex is defined biologically, though, because there is question as to whether sex, you know, is biological, you know, perhaps even with transgender individuals, some of that might even be biological as well. So it's more in favor to say, this is the sex that you were assigned at birth. And it's important to know that sex is not the same as gender. Gender is an identity. It's defined by the person, which can be expressed through behaviors, attitudes, and roles that are typically associated with the societal expectations of sex. But as we were saying before, you don't know someone's gender unless you ask. Just because you think they are behaving in one way does not necessarily mean that's how that individual identifies. And another main reason why it's important to distinguish between sex and gender, and especially in the medical institution, is that these words are often confounded on intake forms all the time, which can be very overwhelming for LGBTQ individuals. And if there's no component that allows for answering for sex assigned at birth and gender, it can be very overwhelming. And that can be a component that makes an LGBTQ person not feel safe, or that their providers are going to be competent enough in their care to not realize that this is a huge difference for people in this community. Next slide. Keep clicking through. So this is a bit repetitive, but so go back. Gender identity is the sense of self. So the sense of being a man, woman, or another gender, which can be neither, a combination of both, or something else entirely. It either conforms to a person's assigned sex, so that's cisgender. So for instance, I was assigned female at birth and I identify as female. So my gender identity is female, but like from a scientific term, one would maybe call me cisgendered, or stray away from that. So that could be non-binary, agender, or transgender. And we can kind of go through those terms later on for those of you who don't really know what either of those terms mean. So gender expression is how someone presents their identity to the world. This can change over time. Typically, gender identity informs someone's pronouns. So if someone identifies as female, they might use she, her pronouns, like myself. If someone identifies male, he, him, his. And then there's also, non-binary individuals, who might use they, them, their pronouns, he, him, his, she, her, hers. And there's also even more language that's being developed for pronouns that if an individual doesn't feel like it fits them, then there's something else that they can use. The only way that we know someone's gender and their pronouns is if we ask. You can never assume just by looking. All right, next slide. So pronouns. So I thought this was a good way to demonstrate the different types of pronouns that are out there, and also to give an example of how you can use they, them, their pronouns. I find that among providers, using gender neutral pronouns tends to be the most complicated. So in the top row, you'll see the gender binary being like the two opposite. You have she, her, hers, he, him, his. I think we all know how to use those pronouns. And then gender neutral. So there's they, them, theirs, z, her, hers, z's or zers. And I actually don't even know how to pronounce the last ones. See, they're always changing. Even I don't know some of these things. So the way I teach people how to use they, them, theirs is just imagine you're speaking to or talking about a group of people. You might say they are speaking, or they went to the mall. The only way to really get good at using this is to practice. And you might even be using they, them, their pronouns without even realizing it. For instance, like if I have a friend who's pregnant and I don't know the gender of the baby, be like, oh, what are you going to name them? So I really suggest you try to practice using they, them, their pronouns, so that if you ever encounter a person, a friend, or a patient who uses these pronouns, you feel comfortable. And then I have a link on the bottom that I found yesterday, actually. That's a nice way that you can practice using those pronouns. Next slide. So this is a picture that I found on Twitter. Here are 10 things you're actually saying when you ignore someone's gender pronouns. This just really stresses the importance of just doing your best to try to get pronouns right and to ask, because if we're not using someone's correct pronouns, we can actually make our patients and friends feel very uncomfortable and unsafe to be around us. And there's a lot of subtext that goes into when you're not treating someone with the respect that we all deserve. So by insisting on someone's pronouns being something other than they are, you're essentially saying, I know you better than you know yourself. I want to teach everyone around me to disrespect you. Because once you start using someone's pronouns incorrectly, you might start enabling others to kind of make that same mistake. I would prefer it if you stop being honest with me, and I'm not an ally. So really just think about these, try to have them soak in, and think about when someone called you by the wrong name, or think about how that felt. It's obviously not exactly the same experience, but at least a way for you to think about it. If you've never experienced this yourself. Next slide. So sexual orientation. So like gender, this is an identity. It's defined by which gender or genders a person is attracted to. There's a wide range, which include but are not limited to bisexual, lesbian, gay, asexual, pansexual, and heterosexual. And this can definitely change over time. I feel like in our society, we tend to think that gender and sexual orientation are fixed at birth, and that's kind of what you're stuck with. But people are a lot more fluid than that. And sexual behavior sometimes, but not always, dictates sexual orientation. This, I think, can be kind of confusing for some people. I've had people tell me, so you like guys and girls, so that makes you bisexual, right? Well, if you go by the definition, it might appear that way, but, you know, it really depends on the individual and how they see themselves. You know, especially if someone's exploring what their interests are, you know, maybe they still identify as straight but are exploring to see what they do like. So that way, in that instance, sexual behavior doesn't dictate sexual orientation. And in another instance, it might be the person's simply not comfortable to share their orientation with other people. If it's a safety issue, as I mentioned, there's a lot of communities in which sexual orientation and gender identity are not that diverge from heterosexual or, you know, man, woman, you know, might not be safe to be out. Even in the workplace, I've had friends who got fired when they disclosed that they were transgender. So, which is completely horrible. But so it's just really important to know, especially as a clinical provider, that it's important that we respect how our patients identify, but also when taking histories, knowing what sexual behavior that they have to know what diseases or health conditions those individuals might be at risk for. Next slide. Yes, and sexual orientation is definitely not the same as gender identity. This is, if all these terms are new and confusing, this is, you know, probably the first time you'll see a unicorn in a professional presentation. I urge you to go to this website. It's on the bottom left, www.transstudent.org. It's a really good way to visualize, you know, a lot of these things can just be on a spectrum of, you know, and you see for this person feels very female. They feel like they're another gender. They feel like a combination of different gender expressions. You can see that there's the sex assigned at birth. This unicorn's physically attracted to multiple people and emotionally attracted to different identities as well. Again, if you have any more questions about this, I'm happy to explain. But another good thing I like about this is that there's not man on one side and woman on the other. People can feel a different range of masculinity and a different range of femininity all at the same time. And sometimes these ranges can vary throughout someone's lifetime as well. But if you're having a hard time understanding, you can kind of use this to kind of help better understand others. Next slide. So our takeaway points is it's important that we ask individuals what their identity is. Really knowing someone's identity and how their pronouns are key elements to creating a safe space and making sure our patients feel welcome and invited in the healthcare system so that they don't have the fears of discrimination that I explained earlier and then don't even return to the healthcare system to have their healthcare needs met. Being cognizant of all these different terms is really important. It helps strengthen the physician-patient relationship and establishes a foundation to build trust, honesty, and open communication. And so, as I mentioned before, you really can't know anyone's identity unless you ask or the patient explicitly tells you. In the next several slides, we'll kind of go over some inclusive language that we can use to practice. You can always practice, you know, to yourself or on your downtime.
So we thought it'd be helpful to talk about, so how do we actually do this? So we've been talking about it, but what do you actually say? So we'll give an example. Hi, my name is Dr. Deffenbaugh. Please call me Dr. D. My pronouns are she and her. So that's it. That's what we're talking about. One way to do that is to model it for your patients, to introduce yourself, let them know what name you prefer to go by. So your whole last name. Some clinicians like to use their first name, just, you know, call me Nicole, that's fine. And my pronouns are. And then to refer to the patient and say, how would you like me to address you? Or could you share with me? Or do you feel comfortable sharing with me your name and pronouns? Those are different ways of asking the patient and inviting them to share their pronouns and identity with you. Reminder to always ask who else is in the room. The reason we do that is to not make assumptions that it's that person's partner. So it could be a family member, it could be a partner, but then we don't want to say, oh, your husband or your wife. So avoiding binary language, and instead, as Becca had said, to use the gender neutral pronouns like they, and ask, what brings you in today? Or the patient is waiting for you to see them. So again, practicing using they and using gender neutral terms. Next.
And then might I add, just to the ask who is in the room, I'm sure all of us have definitely done this. Like when I was in medical school, we have all done this, where like we see someone in the room who looks like the patient's dad, and you ask and they're like, no, that's my husband. And how stupid does that make you look when you assume who's there, and then that person has to explain themselves to you, and then they have to out themselves. It just makes it makes us, so this is important to do all the time, because you can make anyone feel uncomfortable by assuming relationships. So it's really important, these are just really good tools to use for everyone, regardless of whether or not someone is LGBTQ. This is just a way to make everyone feel safe. Mm-hmm. Next slide.
So some additional recommendations. This is really important as well. Only ask what's relevant to their chief complaint. So if they're there for an earache or stomach ache, this is not necessarily the time to ask about their sexual orientation and gender identity. So don't go beyond what's necessary. I've heard from many patients who said the clinician asked them questions about their sexual orientation, and it was not at all relevant to the reason they were there. Again, be aware of the relationship status. So just asking, are you in a relationship or do you have a partner? Again, avoiding binary terms and assumptions. And then asking for and using the patient's language. We've said this a number of times, and this is really key. So as you're listening to the patient, considering using this language and actually capturing it in their medical health record as well. So what words do they use? So for example, if the patient identifies as lesbian, don't use other language to refer to that patient. Don't refer to them as homosexual or queer. Use the language that they're using. And again, you can always ask for additional language. And finally, this is also really important as well, is information for a patient who is transitioning or transgender or non-binary patients. So for example, to better understand your health risk, can you tell me the following? Like, if you take any steps to transition, can you tell me, if so, what you've done medically or surgically? So recognize at the beginning of this is to better understand your health risks. So to explain to the patient why you're asking these questions, so they don't feel that it's intrusive, that they understand the clinical reason why you're asking the questions in order to better understand and care for them. Next slide. So the final thing I want to say, and then Becca's going to finish with the community health part, is that mistakes are going to happen, and we've all done it. We've said the wrong thing. We didn't mean to say, oh my gosh, I didn't mean that to your father. I apologize. And that's what we want to do. We actually want to apologize. So the left column with the smiley face is briefly apologize. Verbalize what you're trying to do. I'm very sorry that I said that. I'm sorry I used the wrong pronoun. It was not my intention to disrespect you. And then to ask the patient, what language would you like me to use, or how would you like me to refer to you? Assuming you already asked this at the beginning of the conversation, right? What you don't want to do is make long-winded apologies or give excuses. And especially not continuing to use incorrect language. So again, record it in the medical record as you're listening. Make sure to briefly apologize and explain what you're trying to do. But again, use the language of the patient as much as possible. Next slide.
And one good way to, you can eat, like, let's say I were talking to Dr. Deffenbaugh, and I was talking about Dr. Deffenbaugh in front of a partner, and I said, he's doing well. And then I realized I was incorrect, because Dr. Deffenbaugh earlier said that she uses she, her pronouns. So what I would do there is, if I said he, I would say, oops, sorry, she. And you can just you don't even have to say, it wasn't my intention, I'm so sorry, like I'm really trying hard, I promise, because then it makes that person feel like they have to reassure you, which, you know, it shouldn't be up to them to make you feel better about your mistake. It's just easier to just quickly replace it with the right one, because just showing that you're actively trying to do better is going to be a lot more than perhaps some other people in their lives. So even though you're making a mistake, immediately replacing it is better than going on this long-winded tangent, or not doing it at all and ignoring it. That's also bad. So just immediately replace. Anyway, so now we're just gonna, this is the last part before we go into the Q&A panel. I know we're technically done at 11:30 and then we have 10 minutes, but this way we're gonna be done a bit earlier and kind of have like a bit of a longer session. So some community resources, there's Bradbury Sullivan, which is an LGBT community center. It's in Allentown. You know, they're mostly closed for in-person stuff. They're pretty much all virtual, but they're great. They have a lot of support groups for different identities. For instance, they have they partner with the Lehigh Valley Renaissance, which is a transgender group, to have transgender support groups for trans females and transgender males. They also have a non-binary group. They have actually a cancer community support group. And the list just goes on. They also focus on arts, you know, featuring LGBTQ artists within the community. They've had awesome film series. Before COVID kind of ruined that, I had gone and seen a few movies there, which was really lovely. They obviously help and organize Pride. So, and they also provide medical and legal assistance to the LGBTQ community. They have a youth program as well called Project Silk. There's Haven, which is a support group for youth, and there's also the Rainbow Room. Next slide. So there's also a good amount of health resources. There's the Allentown Women's Center. The women part is a bit misleading because they do a lot more than treating women. They do LGBTQ affirming services with the physician there treating 700 to 800 individuals with gender affirming hormone therapy. And he also does reproductive care for LGBTQ couples. There's also Novus, which primarily they have 3, I believe, locations. They primarily focus on STD, HIV care. So like they do pre-exposure prophylaxis for those at risk of HIV, but also HIV treatment. St. Luke's has the Hope Center. It's a Ryan White funded clinic that provides HIV care, but then in the same facility, they also do the same thing with STDs and pre-exposure prophylaxis. And then beyond kind of our local area, there's the Mazzoni Center in Philly, there's Colin Lord in New York, and like the list goes on and on. And there's also now developing online actually medical platforms, because in all of them, they kind of address the disparities that I discussed at the beginning of this lecture, you know, with feeling uncomfortable in the practitioner's office because of fear of being mistreated. Then people saw that as a huge barrier and developed online platforms. So there's the Queer Doc, there is Plume, which does gender affirming hormone therapy, and then there's a new one being developed called Folks. The only downside to these is they can be limiting financially. You have to pay like a membership fee, whereas a lot of these other centers, you know, will actually take your insurance, which finances can be a big barrier for a lot of people. Next slide. If you want to learn more about how you can make your practice more inclusive, these two, so the Fenway Institute has a really good PDF that you can look up. Same with, I believe the one on the right is from a New York hospital. I'm happy to email anyone some of these PDFs. Next slide. These are a lot of different websites that you can use as resources. The CDC has robust kind of like research information about health disparities, but then a lot of these other ones kind of do consistent, up-to-date information, educations. There's definitely a lot of online learning modules on Fenway. There's the Gay and Lesbian Medical Association that if you join, then you can have your name listed in a list of LGBTQ competent providers that patients actually look through sometimes to look for providers. There's WPATH, which is the World Professional Association for Transgender Health. For anyone who's interested in doing gender affirming hormone therapy, they have an entire PDF which is used globally to help guide practitioners in doing gender affirming hormone therapy. There's the Human Rights Campaign, which obviously focuses a lot more on the political platform in terms of making our world a lot more inclusive for our community. And then there's GLSEN, which helps students and teachers and parents help make the community much more safe and inclusive for students and youth. Next slide. So we went over a lot today, but thank you so much. I hope you learned something. And now we're going to open it up to questions. Nicole is going to moderate, and she's also going to just give a little introduction for Sandy and Deb, who are also joining us now.
So thanks again for everyone who participated. I saw there was a chat where someone asked to posting the practice link. So maybe Erin can do that as well. I want to introduce our other two panelists who are here. I'm very excited and honored to introduce Sandy Messick. She is the Manager of Diversity and Inclusion for St. Luke's University Health Network. She is a registered nurse, certified nurse midwife, and she's also a trans woman who socially and medically transitioned 44 years ago. So welcome, Sandy. Thanks for being here.
Thank you, Nicole. Glad to be here.
Thank you. And Deborah Strauss, who is a psychotherapist at St. Luke's Psychiatric Associations in Bethlehem. She's over 25 years of experience working with individuals, couples, and families. And among her areas of specialty are co-occurring psychiatric and substance use treatment, dialectical behavior therapy for treatment of personality disorders, use of mindfulness-based strategies for mood regulation and anxiety management, and affirming mental health care for members of the LGBTQIA+ community. So welcome, Deborah. So my first question to you both, and then I'll go to the questions in the group chat, is to have you share an experience as a queer LGBTQIA individual that helps exemplify a point that was made in the presentation. So Sandy, would you like to go first?
I like to tell a story about when I was a young trans person living in Philadelphia, and I had started hormones, and I was trying to navigate living as a woman full time. So during the daytime, I was still presenting as a young man, working in a deli. And during the evenings, I would spend my time in my chosen gender expression. And one day working at the deli, I had been on hormones by that time for a couple of years and was fighting very hard to disguise the fact that I had breasts. And so I was working in the deli one time, and the Philadelphia Department of Health showed up and said, "You have to go to the public health department right now and go get a chest x-ray because we're screening for tuberculosis at the time." And so I had to do that, and I got segregated in with the male line, and it was sort of like being in a holding tank in a jail, if I can express that the right way. There were some pretty rough-looking male characters there, and I was trying very hard to keep moving to the back of the line because I knew I would have to take off my shirt at some point, which would probably open up a whole world of hurt for me. And I kept hanging back, not taking my shirt off, when out of the blue, an African-American LPN, she came up to me, looked me in the eye and said, "Honey, how long have you been on hormones?" And that broke the ice. And so she ushered me into a private changing area, waited till all the men had gone in for their x-rays, got me in privately. And to this day, she saved my life. And that is the kind of provider that I've always wanted to be. And, you know, I'm hoping from doing presentations like this that you never know what encounter you will have with a person where you will have a profound effect on their life. And so I share that story just because it's what we do as providers.
Thank you, Sandy, for sharing that. That Wow, what a fabulous story. Really profound. Deborah?
So I have two things to share, and one of them goes right to the age discrepancy. My wife and I are 12 years difference in age, and I am older, and I have a little bit of silver here. And the number of times that I have been referred to as her mother is just astounding to me. And it's all levels of providers and support staff who have referred to me as her mother, which then she says, no, this is my wife. And it does make for a very uncomfortable situation. The other story I have to tell is probably, it might be a little too much information, but this is a professional group, so I think it's important to share. There are some times when you might be going to a provider who is not used to their practice being about sexuality. And I went to an orthopedist for a problem with my hand and my wrist. And they asked, in what area of your life is this most problematic? And I said, sexual intimacy. And it became a little uncomfortable because the provider, during a couple of the visits, he brought a student in and said that what he was doing. And when he said something about the area of life, he goes, oh, no, I remember what that was. And then just kind of smiled a little bit, chuckled a little bit, and moved on. And while I stayed with that provider, because that provider happened to be very good at what he did, it really was, it was embarrassing. It was uncomfortable, made me feel like that was not an important thing. Whereas if it was a male going to a urologist for sexual dysfunction, it would be considered a very important thing. So I wanted to share that as well.
Thank you, Deborah, for sharing that. I want to make sure we get our questions. There are a number that have come in, and recognizing the time, I want to make sure that we get these questions in here.
And I have started to type some answers.
Oh, that's okay. So
in the chat.
Yep. So someone asks, is there a movement towards special certification or fellowship training for providers who may want to specialize in care for LGBTQ patients? Becca, do you want to do that one?
Yeah, so also thank you so much, Sandy and Deb, for sharing such personal stories. You know, not everyone's comfortable sharing these things. So thank you so much for being open with everyone so everyone can kind of hear experiences that you've had. Yes, there is a movement. Unfortunately, you know, the American Medical Association was offering a good amount of funding to any organization that developed training for this. It tends to be more encompassing. It does include gender affirming hormone therapy, but also addresses some health disparities that the LGBTQ population is at increased risk of. So HIV, hepatitis, addiction medicine, and so on and so forth. So while they were offering funding, you know, an institution kind of has to have those programs in place to be able to provide the training. So right now, only UCLA has a fellowship and they only accept one person per year. So a lot of times, you know, you don't necessarily need a certification to do gender affirming hormone therapy. There's WPATH, which people use as a reference and kind of just start doing it. And they find mentors in the community who they know do gender affirming hormone therapy, and providers will have them help guide them through treating a few patients before they consistently start treating patients on their own. So this is really something that, you know, OBGYN does, endocrinology and family practice, all three of those can do gender affirming hormone therapy, but there's, at least at this time, there's no certification anyone needs to provide that. So yes, there's one fellowship. Hopefully we'll have more fellowships in years to come, but so far only one exists.
Yeah, Sandy mentioned, do you want to say what you put in the chat box, Sandy?
I believe that Mount Sinai in New York City has a 1-year fellowship, I think, in transgender care. They're doing some outstanding work there with some outstanding providers.
Thank you for sharing that. There are a number of questions about medical records, and I think this is a good one, and I invite anybody from our panel to comment. How do medical records identify biology of birth versus chosen identity, which is important for treatment? So for example, a patient with an abdominal mass who identifies as male may have ovaries that would be important to know in evaluating the mass. And Aaron had asked about changing the intake forms and having our hospitals be more inclusive. So anyone from the panel want to comment on that?
I have we use Epic at St. Luke's, and in Epic, there is a specific gender and sexual identity block where you can use preferred name, you can identify sex assigned at birth, and then there is even another, I think it's in the rooming area, where you can write down the organs that are currently there. So if a trans male still has ovaries and a uterus, that is checked off. So there is that availability within the EHR that we use. The one caution that I have is that we don't want to just assume that because somebody comes in and discloses to us that they are trans, that we automatically say, I'm going to go in and change this person's record, because not everybody wants the record to be changed because other people might have access to that. So we need to be really careful about changing that record with their identified name and their preferred gender identity until they're ready for that.
Yeah, and also a reminder of the Cures Act too. So I think that's interesting. The Cures Act gives patients access to their records, and that many of our local healthcare systems have that. And so patients are able to see it, but if they're underage, their parents have access to the records. And so I think Deborah has a really great comment, a point as well. There are other comments as well about intake forms, so I think we addressed that, but recognizing time, I want to go back. Sandy had given a great example of what she has experienced and how one person made a difference and really changed her life. And Deborah's story as well, I think both are really impactful. So I want to end by asking
Nicole, we have 10 more minutes.
Oh, we have 10 more minutes?
Yeah.
So let me just ask the question anyway about what advice you would give. So 1 or 2 pieces of advice that you would give to provide better care to the LGBTQ plus population. Sandy, do you want to start?
Wow, that's a tough question to answer.
Yeah.
Be an ally, I suppose. You know, take a lot of the points that Becca used about acknowledging a person's chosen gender, for instance, and advocate for them. I've always said that in transgender care is not rocket science. Any practitioner who has an interest in it can do effective transgender care. And I'd be more than happy to work with anybody who wants a little bit more grounding in it. The resource for WPATH standards of care are awesome. They assure safety, they're evidence-based, quite reasonable expectations of both the provider and the patients. But again, just be an advocate.
And I think kind of going along those lines, like one way too is like to remember, you know, I feel like in the confines of like an outpatient practice, we forget that we can reach out, like you can always ask an individual who they are seeing for their gender affirming hormone therapy, and just talk to that practitioner about what maybe you should be looking out for or what resources you can use. Because if someone's providing the therapy, they should know, at least be able to advise you on stuff maybe you can do in the office for your patient. You know, you can always like, if you don't know something, you can always ask the patient to explain, or be like, this is something I might need to learn more about. There are robust resources online. I think sometimes I think people get scared to look stuff up, but we forget that there's so much in medicine that we don't know. We're always looking stuff up. It doesn't just relate to this, but for some reason, when it comes to this, it's like, oh, I don't know anything about it and I can't find out. Well, if you're doing healthcare correctly, you should be looking stuff up and learning new things all the time. So, you don't have to learn everything all at once, but once you have a patient who, discloses their identity to you and you want to learn more, do your part and educate yourself. And if there's stuff that you're confused about, you can always ask, you can always ask me, you can ask the patient, although, kind of being cautious with how much you're asking patients, because patients often complain that like they're educating their providers all the time, which is a burden that a patient shouldn't always have to carry. We do have personal responsibility to look some of this stuff up on our own. But, just remembering like you're not alone. There are resources out there. There's Bradbury Sullivan community. There's all these other community resources. There's online resources. Now you have me, and Sandy just offered her help as well. So you're not alone if there's an issue. So don't hesitate to reach out. Be a good advocate for yourself. Educate yourself. And I feel like the biggest thing is just being open, not assuming, not using bias, because that's what gets us into trouble, again, for everyone, not just LGBTQ patients, as we talked about earlier.
Thanks, Becca. There are some additional comments in the chat box, but I want to make sure we give Deborah a chance to respond as well. So what are one or two pieces of advice you would give to the participants?
So I have two. So one is that there are available online safe space stickers, magnets, things that you can identify your office as being a safe space for people of all cultures. And it usually says something along the lines of, this is a safe space for members of the LGBTQ. It talks about religion. It talks about cultural, ethnic identity, so that this is a safe space for anybody to share about who they are and who they identify as. And the second thing is, you can be the best, most affirming ally provider if you don't train your support staff how to answer the phone, how to greet people, how to be sensitive about using the correct gender affirming pronouns, the correct names. Then those patients will often not meet you as the most wonderful provider anywhere, because they are the first line, they are the first impression for your office.
Thank you, Deborah. And on that same note, you talked about creating a safe space. One of the questions is there a preferred lapel pin or badge or something that indicates to the patient that it's safe for them to reveal themselves and that it's a safe place? Someone's asking for pins or badges. What does the panel recommend? Becca?
Always have like, I feel like a pronoun pin sometimes is good. A rainbow. There you go.
So, sometimes
it's hard because the flag is changing, and there's different flags for each identity within the spectrum. The rainbow tends to be the one that everyone kind of recognizes now. So I feel like at least the rainbow, or having a rainbow sticker that says like, this is a safe space in your office. There's definitely a lot of online resources for that. And kind of going back to the administrative stuff, there's a plethora of online resources for like how to properly train your staff, or even make inclusive intake forms, which I see is a regular question here. You can definitely, I've seen done at these LGBTQ specific facilities, is like, you include kind of all those information, like what's your patient's name, preferred name, sex, gender, and you can even just have a blank space and let a person fill it out. And then, this way they don't have to say it out loud. Someone's like filling it out as they're like waiting to be registered in, or they can be called on the phone by administrative staff. I'm pretty sure it's the Fenway Institute for Health, which would have a lot of these PDFs for like training, administration, and staff. And again, if someone specifically wants those things, I can look them up and give it to you. You know, can email Erin or myself or whoever.
Okay. Sandy, go ahead.
Yeah, sometimes we're rebels within our own institutions, and my St. Luke's colleagues will grin about this when I tell them that we know that having your preferred pronouns on your email signature line is not officially sanctioned by our network, and yet we all do it because we're just rebels. And by the same token, some institutions don't like anything else around a name badge, whether that be a gay flag or what have you. And again, you know, the providers that are really committed will do it anyway. But you know, we also fight that institutionalized sort of stuff all the time.
Two individuals asked the question about EPIC having a smart phrase that could be used to address identity. Anyone want to comment on that?
Yeah, you know, that would be good. I think if someone created it, it would be nice. But EPIC, at least at St. Luke's, does have, it's under the screenings tab. I don't know if this person's from EPIC, but it's under, it's weirdly under screenings. You have to click screenings, and then in that it says like, it's actually not inclusive. It just says gender identity, but the tab includes gender identity and sexual orientation, and includes that organ inventory, which Erin wanted me to address this question. So like, what screenings should you do? Essentially, the phrase that people like to use is screen what the patient has. So that's why it's important to do an organ inventory. You know, if someone is transgender male and they still have their cervix, you know, they haven't had a hysterectomy, they still need cervical cancer screenings. If they, you know, you still need to do mammograms, I believe, even if they've had top surgery as well. So, you know, you have to screen what the person has. And you know, making sure to disclose that with the patient, because some individuals may be traumatized or not like to refer to their, you know, prior organs that kind of associate them with the sex that they were assigned at birth. So making sure you're saying, you know, like, for health reasons, I need to make sure we address this because you've had these organs at some point. We need to make sure we screen for cancer, for, you know, but kind of explaining it from a health perspective, why we need to do what we do. And
so
yeah.
Thanks to our panel. I see that there's some comments about LVHN has mandatory online LGBTQ training.
That's awesome.
Right, so Becca has created an LGBTQ MEL module, which is my e-learning. There's diversity that's going out. So I think change is happening, but I think it's important for all of us to be a part of that change. So thank you so much to Sandy and Deborah and Becca for being on this panel and answering all these questions. And I'm going to turn it over to Dr. Markston to conclude.
Can I think I can quick answer too in like less than a minute. Issues with insurance, I mean, Bradbury Sullivan Community Center, I think, can help if they're having issues with insurance for certain things. So you can always reach out if you don't really know how to help someone with that. And then pediatricians, you know, definitely, but if you go to the WPATH standards of care, like, it'll give you information on how to address pediatric individuals who are interested in transitioning. You know, at the way younger age, you tend to not start anyone on gender affirming hormone therapy because a good percentage of those very young will not necessarily end up maintaining a transgender identity, but may go on to be like lesbian, gay, or some other identity within the spectrum. That being said, for those who identify as transgender when they're kids, but then that kind of maintains through puberty, those individuals are very high likely to maintain that. And then you can start gender affirming hormone therapy. And anyone who identifies as transgender, kind of like starting puberty, moving onward, those individuals also kind of maintain that. And the WPATH has like a whole list of how, you know, it's a bit complicated to get hormones, which is good because we make sure that we're addressing all health needs before we start doing the transition. Bad sometimes because some people really need it, and sometimes having a lengthier process makes it a little more complicated, but peds are definitely being seen for this. Was that an appropriate answer, Sandy?
Yeah, that's really a good answer. And yes, we are seeing more of this among the pediatric population. Some research shows that gender identity is pretty firmly established by the age of 3 years old. But there are concerns about whether this is persistent, because let's face it, all kids play around with gender at one point or another. So is it really a gender identity issue versus just exploration? And that's where our colleagues like Deb Strauss and counseling comes in. But the most important development in this whole area is actually delaying puberty in cases where it gives the patient a chance to sort of sort this out. Because really, you know, if you're a trans kid going through puberty and the wrong gender is one of the most awful things that you could possibly experience. And so we can stop that with puberty blockers, let them sort it out, make informed decisions, and then initiate the appropriate hormone therapy. Thanks for bringing that up.
Yeah.
I just wanted to thank all of our excellent panelists and speakers. Obviously, all 4 of you know a great deal about this topic. I think you brought a lot of knowledge and wisdom to all of us, and we'll try to get some sort of email together that you know, first of all, maybe there'll be a link to the recording, but also a link to some of these resources, which I think would be great for all of us. So I really appreciate it. It was terrific.
Thank you so much for everyone for coming, for asking great questions, for Dr. Deffenbaugh, Deb Strauss, Sandy. They're a great support system, and I couldn't have been here without them. So.
Sorry we ran out of latkes and locks at the back of the room today also, and I'm hoping that our one of our future ones will have adequate supply. I hate to apologize for Aaron and Jerry, but they just fell a little bit short today about that. Again, obviously the chat part is open, so you could still affirm your pledge if you haven't already, and save me the phone call. So, that's not you, but anyway, I appreciate everyone, and have a great day before the snow starts. And thanks again, everyone. And be on the lookout for our future brunch get-togethers.